Happy Black History Month and welcome to today's discussion. We must first acknowledge that the past year has been unbelievably traumatic, unbelievably exhausting, unbelievably overwhelming, and many of us have been unbelievably resilient as we have dealt with the impact of the double pandemic of COVID-19 and racism that often fuels racial injustice. Specifically focusing on the impact of experiencing countless lives that have been lost or taken as a result of COVID-19 and racism. As such, we wanted to create a space to discuss these experiences and the impact that they have had on the mental health of BIPOC. And as we refer to BIPOC throughout this discussion, we're referring to Black, Indigenous, and people of color. Regarding the title of today's discussion, for many of us, we learned a very valuable lesson as children and often heard our parents, grandparents, and other extended family members say, mind your business. This directive has played a very valuable role, often insinuating that we should stay out of others' business. I believe that the directive is an intergenerational transmission of cultural knowledge that often inform the very survival of BIPOC. We wanted to reframe that term as it relates to mental health and encourage individuals to begin to change the mental health narrative by engaging in a process where we collectively mind our business, where we begin to not only practice self-care, but practice caring for each other, which means that we may need to get in others' business. And there are numerous culturally appropriate, culturally sensitive, and culturally respectful ways in which to do so. Therefore, it is my pleasure to welcome you all to Minding Our Business, a discussion about racial injustice, COVID-19, and mental health for BIPOC. I am Dr. Dion Smith Kokorapia. I'm an associate professor and adolescent psychologist in the Department of Psychiatry at Georgetown University Medical Center and MedStar Georgetown University Hospital. I currently serve as the faculty co-director for the Gender Justice Initiative, along with Dr. Denise Brennan. The Gender Justice Initiative is a multi-campus and multidisciplinary initiative developed to promote scholarship that explores and addresses gender justice in all forms. We are also very focused on the intersectionality of these issues. Our leadership team also comprises a steering committee that includes Dr. Christy Graves and myself representing the medical campus, Dr. Denise Brennan representing the main campus, and Professors Naomi Meze and Deborah Epstein representing the Law Center. Last, but certainly not least, we have a phenomenal director, Dr. Melissa Hafaf, who will now introduce herself and acknowledge our co-sponsors. Melissa?
Hi, everyone. Thank you, Dr. Kokrapia. I'm very happy to be here today and to have you all join for this very important conversation. Um, my name is Melissa Halfaf. I'm the program director for the Gender Justice Initiative, and I would like to acknowledge today's sponsor and co-sponsors actually of the event. Um, so we have the Counseling and Psychiatric Service at Georgetown University, CAPS, as well as the Office of Student Equity and Inclusion at Georgetown University main campus, the Office of Diversity, Equity, and Inclusion at Georgetown University School of Medicine, as well as the Office of Equity and Inclusion at Georgetown Law. And finally, the Women in Science and Education, who have all been generously sponsoring this event today.
Thanks, Melissa. I
Thank you.
will, you're welcome. I will now briefly introduce our esteemed panelists who will then provide more details regarding their background, areas of expertise, and they may even want to make a statement about why they are committed to this work. Dr. Gioni Lewis is an associate professor of counseling psychology at the University of Maryland at College Park. Dr. Joellen Walker is a counseling psychologist at the Georgetown Counseling and Psychiatric Service, and she also serves as the wellness director for the Georgetown Scholars Program. Dr. Christine Goins is an assistant professor of clinical psychiatry and a child and adolescent psychiatrist at the Georgetown University Medical Center and MedStar Georgetown University Hospital. She has also served in the role as chair of the department's Equity, Diversity, and Inclusion Committee. Dr. Corey Williams is an assistant professor of psychiatry and a child and adolescent psychiatrist, also at Georgetown University Medical Center and MedStar Georgetown University Hospital. Thank you all so much for joining us today. We really appreciate you sharing your expertise with us and the audience. And I'd like to now invite each of you to share a little bit more about yourselves. Dr. Lewis, would you like to start?
Sure. Good afternoon, everyone. I'm really excited to be here. Appreciate the invitation to speak today. So I'm Gioni Lewis. I'm an associate professor of counseling psychology at the University of Maryland College Park within the Department of Counseling, Higher Education, and Special Education. My research is focused on investigating the influence of discrimination on the mental and physical health of Black, Indigenous, and people of color, with a specific focus on the impact of gendered racism. So, really exploring the intersection of racism and sexism experienced by women of color, as well as resilience, coping, and radical healing. I'm also the current president of the Psychology of Black Women, which is a section of the Society for the Psychology of Women from the American Psychological Association. So my research, teaching, and scholarship is all grounded in my passion and commitment to social justice issues. And so this conversation is very important and timely. And I hope we can talk more about really the ways in which racism and discrimination has exacerbated a lot of issues for BIPOC communities. So looking forward to our conversation today.
Thank you, Dr. Lewis. Dr. Walker?
Good afternoon, everyone. It is a pleasure to be here speaking with you. I'm Dr. Joellen Walker. I use she, her, hers pronouns. And as was already mentioned, I'm a licensed clinical psychologist. I'm a staff psychologist within CAPS, which is the Counseling and Psychiatric Services. And within the Georgetown Scholars Program, I serve as wellness director, which includes some direct services such as individual and group therapy, also other types of wellness programming, and just integrating that health mindedness into the program as a whole. GSP, as we call it for short, serves our first generation low income undergraduate students on the main campus at Georgetown. And I also do some private practice in the community. I primarily work specifically with members of marginalized groups and especially women of color. And so really excited to kind of educate and learn from one another, exchange this information about such a timely and important topic.
Thank you, Dr. Walker. Dr. Goins?
Hello, I'm Christine Goins. I am a child and adolescent psychiatrist. I have clinical and teaching interests in community and school-based mental health, as well as integrative psychiatry. I have served as the chair of the Equity, Diversity, and Inclusion Committee for the Department of Psychiatry at MedStar Georgetown University Hospital, and also serve as the Assistant Program Director of the MedStar Georgetown Child and Adolescent Fellowship Program. And I'm really honored to be here with all of you today and to have this fruitful discussion.
Thank you, Dr. Goins. And Dr. Williams?
Hi there, I'm Dr. Williams. I'm just so honored and thrilled to be a part of this esteemed panel and to have the invitation to be a part of this really critical conversation. In this kind of space, I always like to start off with the fact that I'm a descendant of African slaves, and you couldn't understand anything about me unless you understood that. So I like to start off my introduction that way, in terms of just being the offspring of the communities that came out of the South, escaping the brutalities of Jim Crow and the cotton fields of Alabama. And that has driven my passions, my interest, and the core of my identity. Professionally, I'm a child and adolescent psychiatrist. I have an outpatient practice at Georgetown where I see kids as young as 5 and 6 up to young adults. I work on a school-based mental health program with Dr. Goins called the WISE program. And I also conduct community participatory research focused on early childhood development for predominantly Black families in Washington, D.C.
Thank you, Dr. Williams, and welcome again to each of you. Before we begin this discussion, I'd like to ask that we observe a brief moment of silence to recognize the countless lives that have been lost as a result of both the COVID-19 pandemic and racism and racial injustice. Please join me. Thank you. The first part of this discussion, we are going to engage in a process where we set the stage. We're really going to dig deep into the presenting problem, what's going on, what's been going on, and how do we make sense of it all. So I'd like to ask each panelist to initially start us off by sharing one word that comes to mind when you think about 2020 and the impact of racism, racial injustice, and the COVID-19 pandemic on the lives of BIPOC. Dr. Williams, would you like to start us off?
Emergency.
Emergency. Dr. Lewis?
Exhaustion.
Dr. Walker?
Trauma.
And Dr. Goins?
Illumination.
Thank you all. I think that the audience and certainly I can relate to all of those terms, and I'd like you to hold on to those terms because we're going to revisit them later on in the discussion. Dr. Williams and Dr. Goins, considering your work in support of children, adolescents, and families, please share your observations regarding the manner in which your patients, their families, and/or BIPOC communities in general have been impacted by this double pandemic. And I'd like you to speak specifically to mental health implications. Dr. Goins, would you like to start?
Sure. I've noticed during this period, particularly of school closure resulting from COVID-19, I've seen children, adolescents, and caregivers that are really experiencing prolonged and collective stress, anxiety, and depression related to, death and illness of family members, social distancing from friends, extended family, teachers, colleagues, exposure to really traumatic and frightening news and media, a lot of parental job stress and job loss, and parents really being propelled into this role as educators while they're either working from home or either providing essential services. And so consequently being less able to assist their own children with virtual learning. And some even being less engaged in assisting their children just because of their own stress and mental health concerns. Yes. And while simultaneously just not being able to share their child rearing responsibilities with caregivers that they previously relied on. And some of the children who have, I think, been most vulnerable to some of the school closures include children who really rely on school-based mental health and experience disruptions in access to their care. Because services that the school was previously providing, such as obtaining medication from the pharmacy or medication administration, those services were discontinued at that time. And so I've seen COVID-19 related stressors really only compound some of the existing stressors related to disparities among particularly low income BIPOC communities who had resource limitations with limited access to technology, laptops, broadband internet, and data plans, all of which impact children's ability to engage in virtual learning. And school also being playing an important role in physical activity, which is also important for mental health. Yes. And providing a safe, supervised place for recess, motor breaks, and also food insecurity. Schools contributing in some ways to that as well. But I think those have been some of the things that I've noticed.
Excellent response. It certainly has been a difficult time for many families, particularly BIPOC families. So thank you so much for your response. And Dr. Williams, would you like to add to that?
Yeah, thank you. And that was beautifully said by Dr. Goins. And I'll just add a couple points. I mean, I think, similar to other systems, COVID-19 has sort of just laid bare and exposed all of the vulnerabilities, flaws, cracks in the school system specifically. And our Black families who have been living on the margins before the pandemic have been pushed even further to the edge of survival. I think that many of our BIPOC families in the DC area and nationally for that matter are more likely to live in multi-generational homes with aunties and uncles and grandparents and not only is that increasing their risk for risk of COVID, but it also has made it much more difficult to find private and quiet spaces for
Mhm.
children to engage in virtual learning and also to participate in their treatments and their appointments. So that's been a reoccurring theme for the children that I see in terms of just finding a space for them to engage in conversation with me as their psychiatrist. Having multiple children having to share multiple devices in the home has also been a barrier to participating in treatment. I think also there's a labor dimension here, which is that many of our Black families are essential workers who haven't been able to do their work remotely.
Mhm.
And the ability to do your work remotely, we found, is a privilege. And so many families, many parents and caregivers are going to work in the mornings or at night, and then relying on extended family or older siblings to help children with their learning or just chores around the house and just keeping the household. And that's been less than optimal.
Mhm.
Um, and I think what's been coming up for me a lot is the children spending an exorbitant amount of time at home, much more than they used to, both because of the pandemic and because of asthma concerns. So many of our children have asthma because of structural racism and environmental exposures and housing quality. Um, our Black children are 3 or 4 times more likely to be diagnosed with asthma. So this presents concerns for parents who are concerned that they're, both that it's wintertime and the pandemic, um, are having their children stay at home for much longer hours in the day, which is causing a lot of strain in the family.
Mhm.
And kids who may be vulnerable to ADHD or learning difficulties are not been able to have the same outlets that they historically been able to rely on in terms of just expelling some of that energy.
Exactly. And you both have done an excellent job of elucidating the impact and the toll that all of this has taken on children and families. And so I'd like to shift gears a little bit here and ask Dr. Walker a similar question about how all of this has impacted the college age population.
Yeah, I think some of the concerns that Dr. Goins and Dr. Williams mentioned were certainly shared by BIPOC college students.
Mhm.
When campus closures first occurred, we think about low income folks of color, students within the LGBTQ and trans communities really experiencing high degrees of housing insecurity for various reasons, not only because the campus closed, but all of those students didn't necessarily have stable living conditions before, or for some folks, if they weren't out at home, they wouldn't have been able to go home because there could have been some safety concerns, and other folks having safety concerns as well. Similar food security concerns. So being on campus and having greater access potentially to nourishment that may not be as consistent in a home situation. I've seen a lot of increases in social anxiety. So, there was that assumption that students had the equipment and all of the necessary tools for virtual learning to occur, and some did not. And the lapse in time between them getting those tools and getting access to what they needed caused some academic delays and disruptions, but also having to be on video and having to deal with some of the synchronous class times disrupting across time zones, but feeling this greater sense of exposure and having a background that maybe in a high density living environment you have people walking through, you don't have the quiet. As Dr. Williams mentioned, that also disrupts being able to access treatment. So if you're thinking about therapy and you don't have a private or confidential space, particularly if your home environment or some of the folks you live with are part of what you are managing and processing, then that cuts off kind of your opportunity to have that outlet for yourself. We know that there's been a disproportionate impact just in general in terms of infection rates, the racialized violence that has gone on, higher job loss rates, which can increase the students' need to engage in caretaking, whether that's for elders, for younger siblings, and also to continue to work themselves, oftentimes in some essential worker capacities. So I think the last thing I'll say is that with the campus closures and how that affects our professional licensure, that was another issue of access to mental health care, where if students were accessing that on campus or somehow getting assistance, and they're now displaced somewhere else, they no longer have that resource, or it's more restricted in terms of the type of care that they can get quickly. And as far as first year students or first year transfer students, really not feeling as integrated or connected to their institution because they haven't had the opportunity to be on campus or to meet their peers in person.
Mhm. Thank you. And it appears that we're observing similar issues and struggles with the college age population as well. Thank you so much for sharing that. And finally, Dr. Lewis, considering your work and research on the mental health of BIPOC, can you help us make sense of what we've all uniquely experienced over the past year from a research perspective? How have BIPOC been impacted? And are there any specific research findings that can shed light on the lived experiences of BIPOC during this tumultuous and traumatic time?
Thank you so much for the question. I feel like everyone has kind of touched on a lot of the common, themes and main points I was going to mention, but I'll just highlight, and I think Melissa also shared in the chat, I wanted to really first highlight some of the statistics on these disparities, because it's like, we know that these disparities are there, we've heard about it, but sometimes we don't know, okay, what are the actual specific numbers, right? So we know, of course, that, there's lots of data that, Black folks and other folks of color are kind of about 1.5 times likely to have increased COVID cases compared to white individuals. We know that, and even for hospitalizations and deaths, right? So for example, Black folks are 3.7 times more likely to be hospitalized for COVID, 2.8 times more likely to die from COVID. And even with here in DC, I kind of looked at some of the data here because there's this COVID racial data tracker that has some information. And so again, in the District of Columbia, Black folks make up 46% of the population, but 76% of COVID-related deaths. Latinx folks only make up 11% of the population, but 23% of all COVID cases. So again, we see these disparities play themselves out. And I think was also touched on, I think it's important to raise awareness about these intersectional disparities. And so again, because there are more folks of color generally who are frontline workers, we have more exposure, but then also that's broken down by race and gender. So just in December, there was a recent report on women and job losses and saying, oh, women have had higher job losses, and saying that COVID is a factor. But actually, when they drilled down further, it was Black and Latina women who accounted for all the jobs lost in December. And actually white women had gains. So again, it just highlights that it's important to really assess some of these disparities that kind of intersect with race and gender. Black and Latina women are more likely to be frontline workers. And again, we know also that as we're talking about these disparities related to COVID deaths, et cetera, and so forth, we know we're experiencing then more trauma and grief, right? Because we've had maybe more people closer to us who have been seriously in the hospital or have died. And so that then exacerbates everything else that we've been experiencing with the pandemic of racism as well. So I think, of course, everybody is experiencing increased depression, anxiety, traumatic stress, and all sorts of other mental health issues, but that's compounded by the racial trauma that we've experienced in the last year and the grief from having more people that we know close to us who have passed away in this last year. So I think those are other kind of things to be mindful of. And again, really thinking about how these intersect with race, gender, social class, and other marginalized identities.
Absolutely. And unfortunately so. I think that what you've shared in statistics and research really speak to the gravity of this issue that we're dealing with during this time. And now that we've sort of talked a bit about the impact of COVID-19, I want to drill down more and talk about racism specifically. And I want to have a discussion about not only racism, but racism as a public health issue. And many others would say it's a public health crisis. And so I'd like to ask our panelists to just talk about that. Talk about how racism is a public health issue. And anyone can jump in. Who would like to start? Why is racism a public health issue?
I can jump in really quick because I also did just want to say a quick point about language for our attendees listening on the call, which is, you're hearing us talk about BIPOC populations a lot. And I just want to acknowledge that term can be somewhat limited because we're collapsing a lot of different communities with a lot of different histories and challenges into one term. However, it can be a useful term in terms of thinking about the ways in which the racial hierarchy that has been present in this country for centuries has operated to oppress Black, Indigenous, and other folks of color in sort of similar ways to disproportionately advantage white identified people. So although there's limitations and there's limitations on the term, and it's somewhat problematic, it does help us to name the ways in which people are structurally oppressed and the populations that are disproportionately oppressed. So it just helps us to give a kind of language there. So I just want to name that for folks who are kind of worried about different communities and how we're not giving nuance to different communities.
Thank you.
To the issue of racism as being a public health concern, I mean, I think this has been the work of many scholars, such as Kamora Jones's work, to help us think about the ways in which racism has been institutionalized in every sector. In the ways in which racism has been so foundational and fundamental to the structure of this society. It's embedded in the fabric of every sector, every institution that you can think of. So school systems, economic opportunities, environmental justice in terms of thinking about hazardous exposures, policing. Everywhere you look, you can find instances of institutional racism. So when we think about racism being a public health impact, we're really thinking about the underlying value system, which has constructed every fabric of our society, and the ways in which we have to start to reimagine and rethink and dismantle structures that have been built on foundations of racism. And then we separately sort of have to think about what it means to be exposed to racism independently of other sectors. So just having been exposed to racism, the increases in stress, toxic stress, trauma, and thinking about sort of interpersonal racism as an independent determining factor outside of other institutional factors.
Thank you. And does anyone else have anything to add about racism as a public health issue, ways in which racism is systemic, structural, and institutional? Dr. Williams chimed in on that a bit. And just specifically how it impacts our health, social health, professional health, mental health, physical health. Any other thoughts at all on this topic?
Yeah, I was just going to maybe jump in and add to what Dr. Williams said, just because I was thinking about, all of the things he said, same sentiments about it's been built into and baked into the fabric of our society in all of these ways. So it's important to be able to better understand how it's systemic and how it's embedded in these ways. And also there's a large body of empirical research on the ways that even experiencing racism and discrimination on an interpersonal level impacts our health. So we know that there's a lot of research that, folks experience greater symptoms of depression, anxiety, traumatic stress, several other mental health symptoms. And then we know there's a lot of research on racism as a chronic stressor and the ways it negatively impacts our physiological health. So experiencing racism day in and day out is a chronic stressor that impacts our cortisol levels, and which are stress hormones, and having that activated cortisol in our bodies then leads to wear and tear on our bodies that then in turn exacerbates lots of health-related issues that we might have. And so that's kind of what's happening in our bodies. But then also, of course, folks could go to their doctors or mental health providers and also experience interpersonal racism as they're trying to seek services, which I know we're going to talk more about later. But again, experiencing these things both impacts us on a physiological level, and then also, we can experience it in all aspects of our daily lives.
Absolutely. Thank you, Dr. Lewis, for pointing that out. And we absolutely cannot have a discussion about racism without talking about social determinants of health. And so I'd like to move into this direction now and ask a couple things. Dr. Goins is going to share a definition of social determinants of health, and then we'll talk a little bit more about how these determinants impact health outcomes for BIPOCs. Dr. Goins, would you like to share the definition?
So the World Health Organization really defines the social determinants of health as the conditions in which people are born, grow, live, work, and age. And so these determinants are influenced by political, social, economic factors that are linked to health inequities. And these health inequities are, not the result of individual behavior choices or genetic predispositions, but are caused by, social, political, economic conditions, including racism. And so the social determinants of health have a major impact on people's, health, quality of life, and include, racism, discrimination, violence as a core social determinant, as it's a driver, as we talked about, of many health inequities. And some others include, safe housing, transportation and neighborhoods, education, job opportunities, income, access to nutritious foods, physical activity opportunities, polluted air, water, language, and literacy skills. And even, juvenile justice involvement is also a critical social determinant of health, because we've seen that racial inequities continue to shape the juvenile justice system.
Absolutely. And as you've shared, we can't escape it. Social determinants are everywhere. They sort of infiltrate every fiber of our being, every aspect of our existence. So we just simply cannot ignore the impact that these determinants have had on the health and lives of BIPOC. And Dr. Williams, if you will, could you just drill down a little deeper for us and talk a little bit more about the role that these determinants have played historically on health outcomes for BIPOC, and more specifically, the role that they've played, and you've touched on this a little bit already, during this tumultuous double pandemic period?
Mm-hmm. Sure. I mean, one thing I'd like to drive home is just, number one, we have to, when we think about health, both sort of quality and quantity of someone's life years, we have to also think broadly, not just about their access to medical care, which is critical, but broadly in terms of the sector's resources that are ingratiated and integrated into the neighborhoods and into the communities, right? So, issues of, like Dr. Goins was saying, issues of food insecurity, issues of poverty, issues of housing instability, issues of quality of education, all these sort of social, so-called social factors are cumulative to operate, to drive differences in health outcomes. And I want to, kind of interject a sort of different, but in a different term, but in the same vein, the sort of political determinants of health, which was Daniel Dawes's book, The Political Determinants of Health. When we think about policies, policies are arguably the determinants of the determinants. So for example, really, I mean, if you think about the history of this country, we really only have had 3 major health policies that have moved the needle. Number one being the Freedmen's Bureau after the Civil War, which was a federal policy to help newly freed Black citizens to getting healthcare. It's also, its mandate was also to provide services to the poor whites that had been disenfranchised by the Civil War. The Social Security Act, which implemented Medicaid and Medicare in the 60s, and the Affordable Care Act of 2010. So when you think about health in this country and policies that drive health, we really only had 3 significant policies. So we've never really, this country's never really dealt with the consequences of its original sins, if you will, or its original brutality, which was the genocide of indigenous peoples and the enslavement of African peoples. We've never dealt with those issues, and so we've just had generations upon generations of an exacerbation of structural inequalities, and policies that have worked to drive resources away from BIPOC communities to white communities. That have been the underlying driving force for health inequalities.
Mm-hmm. Absolutely. Very well said. Thank you so much. And I'd like to round out this part of the discussion by now that we've sort of set the stage and we've had, some discussion around what's going on and how it's impacting BIPOC. I want to focus now on stigma and other barriers to help seeking so that we can begin to transition into understanding what's going on to what can we do about it. So I'm going to open this up and ask anyone who is interested to just frame this concept of stigma for us. Most BIPOC individuals know what stigma is, particularly as it relates to seeking mental health. We know historically the role that it has played as a barrier to seeking mental health and engaging the mental health system and staying engaged in the mental health system. And so can a couple of you just shed some light on stigma as a barrier and just barriers in general, because we really have to begin to understand what's preventing individuals from engaging the mental health care system.
I can jump in. I think that stigma has to do with a negative perception that will be attached to a person for, seeking out services, whether those are medical services, mental health services, or some other resource. And when I think about, how it connects to this conversation, I think about the 3 A's. So accessibility, affordability, and acceptability. I mean, even the title of our event, right? Minding your own business is kind of like, don't air out your dirty laundry, keep those things inside, keep them within, your inner circle. But when we talk about geography, right? So there are rural areas, for example, that have health professional shortage areas, and that is both medical and mental health. Travel and transportation can be a barrier. Having the time to travel and to be able to engage in services. And aside from just availability of providers, there can sometimes be language barriers that will make treatments inaccessible. As far as affordability, I think about folks who are uninsured, underinsured, or maybe just don't know how to use their insurance and where to get that information. Having so many providers that are out of network or private pay, and what that means for who can access services and who kind of has this privilege of being able to obtain treatment. And then the acceptability really gets at the stigma, whether that's internalized, whether those are messages from broader society or someone's inner circle. What have we learned about asking for help? And I think sometimes folks who have marginalized group memberships, it's like, if society is already telling me something is wrong with me, why would I want to add to that? Or why would I want to prove that true, right? So you don't want to confirm any stereotypes that are negative about your group. And sometimes that can cause people to not access help that they need or could benefit from. There's that history of medical mistrust. And even right now, we're seeing people hesitant about the vaccines and things like that because of past wrongs that have occurred. And with that knowledge being transmitted across generations about who you can trust and whether you can trust institutions and systems like schools and government and healthcare. We're seeing more and more stories about people not being listened to when they are with a provider. And so that kind of gets into the relatability factor of the provider and whether they are going to be sensitive to someone, their patient or client's cultural beliefs and worldview. For mental health and psychology in particular, it's based in this very individualistic white male European standard. And so how do we kind of reclaim that as providers to really serve the broader public and appreciate what is good from those origins, but adapt it to who is sitting in front of us?
Dr. Coco Apia, you're mute.
Yep,
there you go.
I was muted. Sorry about that. I think that was an excellent and robust description of stigma and barriers. And if no one else has anything to chime in on with this, I'll just move on. Dr. Williams, looks like you have something.
Yeah, let me just add in one more thing, because I think, when we start having conversations around stigma and distrust, I think if you consider the centuries of exploitation and destruction at the hands of the American medical system and other systems for that matter, I see the stigma and the distrust as not the problem. That a lot of those things are actually appropriate. So I usually say, appropriate mistrust. So the problem is not the distrust. The problem is, how are we being trustworthy as a medical system, as a mental health system, as providers? So the conversation needs to be reframed, not to pathologize the mistrust, because the mistrust has actually been adaptive in a lot of ways. So if I'm a parent and I'm seeking help, at my school's with my school social worker, I might be afraid that the social worker is going to make a report to Child Protective Services on me, which is something that's historically happened to a lot of Black families. Mm-hmm. So it's not for lack of help seeking. Our families want to reach out for help. But given the violence that systems have done to our families, we're skeptical. And that skepticism is protective. So what we need to do is work extra hard to be trustworthy as a medical system. So what does that mean? That means partnering with communities, having a culture of transparency, having training community members to empower to be healthcare providers in the communities. Having psychoeducation programs in the community, recruitment, making sure we have diverse workforces so that when people present for care, there's people that look like them, that understand their history and culture. At every level, we need to be thinking about, how are we being trustworthy?
Yes. Excellent reframe. Thank you so much for that addition. And thank you both, Dr. Walker and Dr. Williams. And, I just believe that it's very important to expose these barriers so that we can begin a process where we can collectively assess the barriers, acknowledge the role that they've played in limiting access to care for BIPOC, and critically analyze ways in which we can engage in a deconstruction, sort of what you mentioned, Dr. Williams, in a reconstruction process that will support future help seeking. So having said this, we are going to now transition into the next phase of our discussion, which is what we're calling treatment planning, intervention development, and strategies. So now we're just going to talk about how can we support BIPOC in this moment. Dr. Goins and Dr. Williams and Dr. Walker, what specific intervention strategies, educational opportunities, et cetera, have you all used specifically to support BIPOC in these times of constant crises? I'm interested in learning more about what has worked, what has not worked, which is just as important, with regard to your specific clinical populations. And if you have any population-specific resources that you can share, both internal to your institution and external, that would be great. Dr. Goins, would you like to start us off?
Sure. I think during this time, one of the things that I've focused on, at least at the departmental level, had been during the consistent crises, transmuting some of that despair into action by trying to focus on developing, a strategic plan or policies and procedures that are related to enhancing, the department's recruitment, retention, promotion, workplace culture, and leadership accountability practices, not only for BIPOC, but for everyone, but really encouraging BIPOC to, let their voices be heard and be engaged in decision-making that will ultimately impact, their lives and patients' lives. As well as trying to work on, different training curriculums, anti-racist psychiatry curriculums for trainees, and supporting other departmental leaders like Dr. Williams, Vice Chair Dr. Beal, and developing anti-racism learning communities for faculty, participating in different affinity groups, and also being a part of other ongoing efforts across the MedStar Georgetown institutions, such as healing circles, which are safe and brave spaces for Black medical students, staff, and faculty. And then also remaining, connected to, anti-racism initiatives across, MedStar, GME's Working Group for Racial Justice, and the School of Medicine's Racial Justice Committee for Change, and utilizing a lot of the anti-racism resource lists that have come out. One that Dr. Williams, introduced me to was the Anti-Racist Daily Newsletter, which is just full of so many enlightening perspectives and information. And clinically, what I've noticed most in need for my families is really addressing the caregiver and parents, teachers, and their mental health. So it's really been connecting the caregivers to mental health resources, which has been really successful, because a lot of times the children are only doing as well as their parents and their caregivers are. And so that's really been my area of focus.
Absolutely. Thank you so much. Dr. Williams?
Sure, and I'm pleased to answer this question, because I think the issues related to self-care and healing have taken on a whole new meaning in the last year, and I think in this gender justice space, it's a perfect topic, because just the idea of self-care, we owe a lot to Black women, to acknowledge that, specifically scholars like Audre Lorde, other radical Black feminists who understood the importance of self-care because of the threats that our community is facing, and because we live in hostile environments. Self-care is a political act, and it's an act of survival. And part of what bothers me is that I think that the term has gotten misappropriated to mean how do we increase our productivity, or how do we keep being a cog in a dysfunctional system. So I want us to, when we talk about self-care, always be thinking about the Audre Lorde definition, which is, this is about survival, this is about community, and this is about a political empowerment as we take care of ourselves. So when I've been thinking about self-care, I think there's along with the other issues of loss and grief and exacerbations of structural racism, historically, there's been a rich tradition of a rejection of the so-called American individualism for BIPOC communities. We've never fully bought into, thinking about the individual as being in and of themselves. We've always been a community-oriented population. Churches, for example, have always been at the center of our communities. And when we have hard times and grief, we, part of what we do is we come together. And so we support each other. And so not having the ability to attend church or funerals and other gatherings, not being able to drop off some food for a loved one, not being able to have dinner with the grandparents, it's just been devastating. It's been devastating. It's really taken away a lot of our main self-care and coping mechanisms and healing mechanisms. So I think what we've had to do is really lean into other forms of self-care and healing. And I usually when I speak to family members or other people, talk to them about what is it that gives them that experience of being nourished, because it might be different from person to person. But whatever that is, it's really leaning into it and being intentional about it. I feel like I should be getting paid by Pfizer, because I've been doing so much psychoeducation around the vaccines with my friends and family, that I feel like, first of all, we all need these vaccines. Let's be clear about that. Everybody get a vaccine. But also, just to the point about organizing, Dr. Goins pointed out, I think part of this distrust and part of the mess that this vaccine rollout has been, it's just been a lack of organization. And wherever Black people are, they need to be organized and empowered. And that's really, in my mind, that's really the answer to what we're talking about here in terms of structural racism and disempowerment is we have to organize and be empowered in every space, every office, every office building, every profession, every sector. There needs to be an organized movement to empower the Black folks in that space, or the BIPOC folks in that space.
Absolutely. Thank you so much for that. Dr. Walker, would you like to add anything here?
I think the only thing that I would add is just saying that, both myself and encouraging colleagues, whether they're on the faculty side or student affairs side, to have explicit invitations to students and whomever they're working with to discuss, current events, to discuss, some of the identity-based violence, and really just acknowledging it, even if you don't have the skills to process it, but not pretending as though it didn't happen. And there are ways to integrate that into whatever type of work that you're doing. Trying to have a mix of formal and informal opportunities to connect with people. So taking advantage of social media, podcasts and things like that, and really reminding students that I work with of the resources that are on campus to meet some of those basic needs that maybe are kind of touch and go right now, but also helping them to think creatively about how they can connect. As Dr. Williams mentioned, how can you maintain those important connections in a safe way? Because those are things that sustain you. And also recognizing the essential nature of self-care and what it really truly means.
Mm-hmm. Connections are certainly critical, as they have been historically and definitely over the past year. Thank you, Dr. Walker. Dr. Lewis, similar question. Can you speak to this topic with regards to research, how you've addressed these issues in your research program? What role can research play in supporting BIPOC who are struggling as a result of this double pandemic?
Yeah, thank you. Yeah, I mean, I think some of, as people, I was hearing other folks, it kind of is all dovetailing together. So it's really interesting. So one thing that I've done in my research lately is really shift my focus to wellness and healing more in this moment, right? And the importance of, I think Dr. Williams was saying something about, not pathologizing communities of color, right? And so part of the idea is thinking about the strengths that communities of color inherently have, and building on those strengths and focusing on wellness. So some of my colleagues and I have developed a psychological model of radical healing. And so we define radical healing as a process of both resisting oppression and racial trauma while also envisioning and working towards liberation. And we actually really draw on, several foundational theories. I think maybe Dr. Williams is going to talk in a bit about liberation, but really it has a liberatory component to it, and the idea of really trying to psychologically liberate folks from oppression, particularly folks of color. And so again, there's this idea of, we have this dialectic between experiencing this onslaught of interlocking systems of oppression and hate, but also just having that envisioning towards justice and liberation. And those are key components to foster. And so some of the kind of elements that we talk about in our model are developing critical consciousness. So really trying to help people develop greater awareness and critical consciousness of systems of oppression and how they're operating in their lives, developing cultural authenticity and self-knowledge. So really, helping empower individuals to connect with the things within their own communities and within their own culture that are important. Radical hope. So, in this last year, with all the onslaught of things that have happened, we have to have some sense of hope that things will get better. Dr. Williams mentioned something about politics. I mean, we've had some things politically that have happened in the last year. I know in the last month, people have talked about feeling a sense of hope about the direction of our future with, of course, the election of our first Black woman VP. And then of course, also emotional and social support and connecting more collectively. You know, again, most BIPOC communities have a more collective spirit and a collective energy. And that is important to lean on those networks rather than trying to kind of go at it alone. And then developing strength and resistance. And so I think, you know, that speaks to some of what we've been discussing already. It's important to empower communities and help communities develop that sense of empowerment, because, you know, that's the way you resist oppression, right? Doing that work. There's also research that finds engaging in social justice issues, engaging in activism, that actually has a mental health benefit as well. So I think that's something that's important to be mindful of. So again, doing research that has these different components, I think is really important as we try to help, again, empower all of us to figure out ways to resist in this time.
Absolutely. And that is a great lead into my next question, where I was going to put Dr. Williams on the spot, given discussions that he and I have had along with other colleagues in our department about liberation psychology and how we might be able to use this framework to transform the work that we do with our patients. And so, Dr. Williams, could you just briefly share with the audience, what is liberation psychology, and, you know, what role can it play in our work as mental health professionals?
Yeah, thank you. I know I'm glad to address this question because, as you know, we've been talking a lot about this concept, and I don't consider myself an expert, but someone who's just grappling with it, and you know, I still consider myself a learner in the space. But when I think about liberation, you know, I really think about the heart of what it means to be well and to heal in BIPOC communities, right? So liberation came out of, you know, social justice movements, Paulo Freire in Latin America, and Black Panther movements here in America, that essentially asserted that you can't understand someone's inner life without understanding the structures of oppression that they're subject to. Right? There's always this tension between what's going on in my intrapsychic space, and what are the broader structures that I'm situated in. And so we can't understand people clinically if we don't understand the structures that are oppressing them, whether it be exploitation at work, whether it be structures of patriarchy in their relationships or in their families, whether it be structures of sexism that are playing out for a particular patient, structures of poverty, housing instability. So what we've done is, in mental health, is that we've taken an overly reductive view historically and have over pathologized BIPOC presentations and mental health, because we have not considered the structures and the stressors and the challenges in which they're truly dealing with. And so as a clinician, you may not necessarily be able to deal with those things directly, but what we can do is help understand people in context, and also help give people, connect people to broader empowerment movements and organizations that can help them to feel like agents of change. Because I think that for BIPOC folks, when we talk about liberation, it's always been connected to resistance. It's always been connected to feeling empowered. And it's been connected to feeling like we are connected to our history and our ancestors, which is fundamentally an anti-colonial concept. So liberation is about taking people in context, understanding the structures of oppression and racism in which they live under, how that impacts their presentation, and how we can empower them to being an agent of change.
Thank you so much for that. I'm looking forward to continued discussions around this liberation psychology framework. And I mean, I know we could have another whole webinar on that alone. It's so critical to the work that we're doing. So thank you for at least sharing that with the audience. And I'm going to wrap up this section by making this statement. You know, often we focus on strategies and interventions for our patients and research participants. However, not as much focus has been placed on mental health providers, specifically BIPOC mental health providers, when it comes to self-care. So I'm excited that you all have already touched on that subject in some of your responses already. But in my opinion, over the past year, more than ever, BIPOC providers have been functioning as what I'll call wounded healers. In essence, we have been functioning in healing capacities while being traumatized ourselves. And so my question, which if anyone else would like to jump in and add to this, you can, but I think we've covered some of this already. My question is that how do you practice self-care as a BIPOC mental health professional? And what can you share with other mental health providers about practicing self-care during these challenging times? I know for a fact that we, other mental health providers, are struggling. We are struggling. You can't struggle. You can't not struggle after experiencing what we've experienced over the past year. It's inevitable. And so I think it's really important for us to continue this discussion around self-care. So if anyone else has any other thoughts about self-care, about specific things that you do that you'd like to share, that would be great. And if not, we'll go ahead and wrap this section up and move on. Any other final thoughts about self-care, specifically as it relates to providers?
I was just going to share just some of the ways that I've been learning, been doing so in the past, but then also learning new ways of, caring for myself, and, including, swimming and yoga and nightly prayer groups. One of the things that I've also been learning is how to protect my time. And I feel like particularly in academia, you're waiting for a system to give you protected time. But, to the point of, Dr. Williams mentioning, liberation and empowering BIPOC folks, really trying to empower myself to protect my own time in different ways. And whether that means that I need to say no, even to an opportunity that I'm interested in, that's something that I have to do at that time in order to have the, adequate amount of rest that I need. And also protecting my energy. So, delivering myself from toxic environments, and that could be a relationship, that could be a role, that could be the news for a period of time. And so I would say, in addition to, spending time with people that I love, shutting myself off from technology when I need to, being okay with laying in bed, doing nothing, journaling, listening to Jill Scott, just chilling. Yeah. I think it's also one way that mental health professionals can engage in self-care is by just taking an inventory of their lives and having the willingness to release anything and everything that doesn't serve their highest selves, their highest good, and doesn't prove to be generative.
Absolutely. And I think we can all relate to everything that you just shared. Thank you so much for that. Any other?
Can I add just one little piece? So yes, I doing all the stuff that Dr. Goins mentioned for sure. Kind of virtually connecting with folks. I also, and engaging in mind-body interventions, right? Like yoga, meditation, those things being important, particularly for Black women. It's important to kind of get into your bodies. Often we're socialized to be doing a whole lot of different things and kind of internalize that strong Black womanhood narrative, but we really need to take time for ourselves a lot of times. And so one thing that I've done in my role as president of the Psychology of Black Women is actually started these radical healing circles for Black women. And so we've been having kind of monthly, similar to, I think Dr. Goins mentioned, like the healing circle idea. So we've been doing these monthly healing circles, and we started off in the fall where they were more process oriented and really getting folks to process and talk about being psychologists, whether it's in practice or in hospital settings or, academics, all of our various roles that we play and hats we wear, but really making space and time for ourselves. And then this month or last month in January, we transitioned because we really got feedback that people wanted to do other things. And, as psychologists we can, and psychiatrists, we can talk, and that's a means of healing, but it's also important, again, to get out of our bodies in ways. So we did a, trauma-informed yoga just a few weeks ago. We're going to do, a virtual paint night next month. So trying to find other ways to connect with other, particularly in this case, Black women, and really get ourselves to have ways that we connect and think about the uniqueness of the issues that we have, but also find other ways to connect and heal. So I think those are just some other things I would add.
Absolutely. And I think that it's important for us to be deliberate about self-care. And Dr. Williams, I'm going to use your term here, be not only deliberate, but unapologetic about taking care of ourselves. And I think that sort of is what Dr. Goins was mentioning earlier. So I'm going to thank you all so much for all of those tips. I hope that they've been very helpful to everyone who's joined us today and helpful to us as well. Now that we've sort of set the stage around this issue, and we've talked a little bit about intervention, development, treatment planning, and strategies, let's shift gears a little bit here now and talk about maintenance and sustainability. And our overarching question here is, how do we maintain and sustain our efforts? So in this section, let's think about how can we use our clinical practices, our research efforts to develop culturally appropriate ways to address BIPOC mental health. And in this section, I'm going to just throw out some topics here, and you sort of chime in where you fit. So what role does community engagement play? What role does education and training play? And what role does advocacy play? Should we even be serving in the role of advocates as mental health professionals? Um, and so let's talk a little bit about, we've set the stage, we know where we're going, we have these strategies. How do we sustain all of this? How do we keep it going? How do we take care of ourselves, our communities, particularly our BIPOC communities, and how can each of these areas play a role in that? So let's start off with, let's see, Dr. Walker, do you want to jump in and talk about any of these areas that I shared? How do we sustain our efforts and maintain the work that we're doing?
So I think about this in terms of either where we can continue to build or, some things that are maybe lacking that we need to enhance. So when I think about graduate training, education, having more about cultural sensitivity, racial responsiveness, and how you incorporate that into treatment. As my fellow panelists have mentioned, how are we being trustworthy, and how are we partnering with the communities that we're saying we seek to serve? Instead of going in and assuming that we know best, how can we really notice who is missing from whatever platforms that we're on, the tables that we sit at, who is missing? How can we point that out, raise awareness about that, bring people to the table and pass along the mic for them to then tell their own narrative instead of us assuming we know best and kind of imposing our own values and solutions on these communities that we're hoping to serve. What was mentioned before about that, just the power of coming together in a space and having that familiarity and kind of being able to breathe. That is just so essential to healing and thriving and resilience, how you can bounce back and having your feelings and your identity validated. So really thinking about how do we connect clients, patients, students, and really encourage them to embrace that. And also to be still, to be okay, not having an agenda for minute to minute, but sometimes just coming together and being together can have a real impact.
Mm-hmm.
And I think also being willing to make mistakes. We all mentioned some areas of expertise, and I know that's a term that I sometimes shy away from because I feel like I'm always learning and I'm always seeking to grow. And I think in order for change and progress to happen, you have to be willing to make mistakes, do your best, apologize when things happen, and learn from that. Because if we are so concerned with getting it right, we're probably not going to be having the conversations we need to have. So I'll end there.
Exactly. Thank you. Other thoughts about maintenance and sustainability of efforts?
Well, I can jump in just because I also was going to speak about education and training, so I could piggyback on what Dr. Walker said. I'll just briefly, I think teaching our students and trainees about obviously cultural competency and some of these issues, but also social justice advocacy. So that I think that that's something that's really important. In the previous training program I worked in, we actually had a social justice practicum course for our counseling psychology doctoral students, where we train them on developing social justice advocacy skills and how they could actually intervene on a systems level, because often, they learn the individual therapy skills, the group therapy skills. But again, a lot of our clients and patients' issues are rooted in these systems of oppression and how those impact their health and well-being. And so trying to actually do things to ameliorate some of those systems of oppression also can benefit our patients and clients. And so I think more training programs in psychology, psychiatry, et cetera, should try to really infuse social justice advocacy, because that's something that, again, we need more students to develop those skills so that then they can do a better job of not only treating their patients and clients within the room, right, and within the session or in these various ways, but then also outside of it and advocating on that larger, systems level. So right now, we have this COVID relief bill that needs to get passed, and thinking about, well, what could we do in our own roles to advocate on Capitol Hill to ensure that that gets passed, because we know that'll disproportionately benefit BIPOC communities. So I think those types of things are also important as we think about education, training, and kind of building this movement for our profession.
Thank you. And Dr. Williams, oh, you're going to probably jump in. I was going to ask you to see if you wanted to add anything on this advocacy piece, because I know that you've done quite a bit of thinking around that topic. So
yeah, thank you. Thank you for the segue. Yeah, I mean, I think that's been one of my major concerns, is how do we sustain this momentum? Because I think we have seen some fantastic momentum and opportunities in this time, as tragic as it's been.
yeah.
There's been a progressiveness of conversations that I haven't heard in recent history. And we're seeing some really valuable momentum with Black Lives Matter and other activist movements. And part of what I see as one of my core professional responsibilities as a provider is being an advocate in some way. And I think it really depends on your profession and what you do, what the spaces you're in will dictate what that looks like for you. But as we think about educating students at every level, they need to understand what are the main drivers of health. And if you're taking seriously the main drivers of health, then it is our core professional responsibility to be advocates and at times activists, which is at times we have to step outside the system to really push it where it needs to go. So not only is advocacy and activism important, I think it's a core professional responsibility. I mean, the problem is we don't necessarily get paid for it. And a lot of times we get, it's on us and it's our own invisible labor. So that's definitely a problem. But the way I see it, if we're talking seriously about health, then we all need to be advocates in some way. And I think the other piece in terms of sustainability, is just comes down to resources. I mean, for me, if you think about the stimulus bill, for example, the CARES Act that came out in, it was April or May of last year, that was a $3 trillion bill to stimulate the economy. I mean, that is just mind-boggling, unfathomable power. And so from that, I think we need to be unapologetic about how much we ask for. Like my concerns about cost has gone out the window. I don't want to hear anything else about how much things cost. All these budgetary constraints, or some of those things are real, but a lot of it is just manufactured, and it's a way for it to stall progress. So we need to be unapologetic about how much we ask for if we need it. And we need to have a racial politics about what we ask for. If the Black students want a Black space, they should have that space. If the Black faculty need an initiative or a space, they need to call it what it is. We have a racial politics to what we want, and we're not going to apologize for having a racial politics.
Well, there you go. Very well said. And I'm sure it was very well heard. Dr. Goins, I want to make sure I include you in this discussion. If there's anything additional you'd like to add that hasn't already been shared.
I think that they really touched on some of the, most pertinent aspects of sustaining these efforts. I think if anything that I would add is just remembering to also listen to our bodies, listen to our minds, and recognize when it's time to take a break. And that's also a part of movement work. You know, when we think about community activists and artists like, you know, Trisha Hersey of the Nap Ministry, and even, you know, other predecessors like Dr. Williams mentioned, Audre Lorde, and the fact that rest is also resistance, rest is also a form of reparations, and self-care and preserving yourself is also movement work. And so that's okay too.
Absolutely. And thank you all for chiming in on this section. I was going to round it out with another question, but I'm actually going to take the liberty of converting that question into a statement to lead us into the Q&A section. You know, I think that based on what we've heard today, based on all of the knowledge that has been shared, it's critical that we begin to change the narrative to ensure that BIPOC mental health not only remains a priority, but that it is considered an appropriate and acceptable option for BIPOC who are struggling through crises and traumatic events like racism and the COVID-19 pandemic. So I'm just going to leave that there for now. We're going to go into our Q&A. I'm hoping that we have some questions from our audience. We have over 160 registrants for this discussion, so I'm sure there are a lot of questions. We may not be able to get to everyone's questions, but please know that we appreciate your time and your commitment to talking about this very important issue, and we're happy to be available after this webinar to have any further discussions with any of you. But let me pull up the document to see what questions we may have for our panelists. Okay, I want to start off. First question, and any of you can feel free to jump in, maybe our clinicians. What suggestions would you give to members of BIPOC communities when selecting a mental health provider? Any suggestions?
Yeah, I was gonna. I think that question kind of evoked a couple things in me. I mean, I think you can seek out. You know, there's organizations, nonprofits out there that do mental health work specifically targeted for BIPOC communities. One of them being Therapy for Black Girls. You know, is a good one, important one. And there's a number of programs out there that are specifically focused on that. So I'd encourage some. You know, we can also send out some resources if folks want that. And then also asking, I think we don't do that enough. So when you call and make an appointment, say, I prefer a clinician of color. I think that's totally fine and appropriate. And you may or may not get it, but depending on availability, but we all have the right to ask. And it means something different. To be clear, you know, when a white person wants a white only care, I mean, that's something different. That's reinforcing white supremacy. But when a historically oppressed person, BIPOC person, asks for a clinician of color, that's about connection and cultural understanding. So it means something different. So go ahead and just ask when you're making appointments.
Exactly. Any other thoughts?
I think a lot of clinicians will offer some type of consultation, or you have some contact with them before you start treatment. And similar to what Dr. Williams mentioned, I really encourage people to feel empowered in their right to ask questions about what is important to you. You know, whether that's you want them to have a solid understanding of social justice, or you want to understand how they incorporate that into their care with you, really asking those questions, whether it's beforehand or once you get started, and knowing that it may take a couple visits for you to really feel it out and see if what you're looking for is there, and not being afraid to leave the situation if it's not working for you. And that can be so difficult because it can be so hard to take the step to access care, to get connected. And, you know, then sometimes people will stay in a situation where they don't feel they're benefiting. They don't feel like they're making progress on their treatment goals, but really knowing that it was within your right and it's important for you to really be getting something out of that time. So if it's not working out, whether you're working with a person of color, as a person of color or not, to really, you know, care for yourself in that way and step away and look for someone new if you need to.
Thank you. Another question related to therapeutic interventions and the therapeutic process. What help can you offer to white therapists that work with BIPOC clients to make sure that we move our clients in the right direction while doing no harm? Who'd like to address that question? Any advice from anyone?
Yeah, I'll offer a comment. I mean, I think it starts with it starts with recognition of that problem. I mean, the way that the question was phrased, you know, how does my whiteness, how do I prevent my whiteness from being a barrier to facilitating a connection with a particular client or patient? I think for, you know, for my white colleagues, I always say it's really important for you to have the ability and the comfort level of just being able to name your whiteness and understand, ask a question about how it might be impacting the encounter. It may or may not be, but just being willing to offer that and put that on the table can be a liberating experience actually for a lot of families. Just knowing that they have a therapist or clinician that is willing to talk about racial issues, that can really, you know, open up the floodgates in terms of things that they really want to talk about.
Yeah, and I'll just add that, yeah, I mean, I think just having some cultural humility, right, and being aware of what you don't know, rather than assuming or trying to be like you're the expert and that you know about communities that you don't. You know, a lot of my research also focuses on microaggressions and kind of subtle forms of racism that you can perpetuate in therapy and in various settings. And so being mindful not to equate your oppression if you are another marginalized group, but not making, you know, equating that to maybe a client of color and their experience. So I think there are a lot of things that are important to do for you to unlearn your own white supremacy, frankly, through kind of readings, education, et cetera, but doing that work so that you're not expecting your patient or client of color to teach you, right? I think that's a big thing that's important.
Thank you. Let's try to get a few more questions in here. Let's see, what long-term effects of COVID might we see on BIPOC Black communities after we return to normal? Can we prepare for and mitigate these now as we move forward, and how? Any thoughts about long-term impact of COVID on Black communities or BIPOC communities, and how do we sort of get in front of it?
I mean, one thing I'll just offer, just because thinking about mental health effects, right? Because we're still learning what the physical health effects and long term of having COVID are, and the research on that. But again, as we talked about, BIPOC folks are more likely to be experiencing all kinds of grief and more grief than white folks, particularly if they've lost lots of people. And a lot of times it's more of a sudden death situation. So just trying to kind of get in front of that means trying to do some of what we're doing to demystify things around mental health and seeking treatment, making services more accessible to folks. Like I think Dr. Williams mentioned therapy for Black girls or all of these other resources. I think it's important to just try to make mental health services more accessible to folks, and make space or time, if you can, to do some sliding scale work or work for, pro bono or something, because people are hurting and in need. And I think that that's something that's that we could all try to find ways to contribute to support BIPOC folks as we transition to whatever this new normal will be, because we won't get back to normal.
Any other thoughts before I move on? Okay. So here's a question that I might be able to answer quickly. Are there resources for Black, Indigenous, Latinx, and other students of color that wish to set up and facilitate healing circles or spaces? And how can faculty best support and hold these efforts? You know, we have our Racial Justice Committee for Change has engaged in a very intensive process of thinking about how we can address issues of healing, specifically for Black medical students here at Georgetown. And so we have tons of resources that we can share with you to help with that effort. And if you would just reach out to us at Gender Justice Initiative, I can connect you with those resources and help you get that process going. Another question that I can also answer is, hello all, I'm a Black grad student at Georgetown. What books or podcasts would you recommend or be willing to share in the chat for radical healing for BIPOC women? If you all would like to add anything to the chat, please do so. But we're also going to ask our panelists to send in some resources that we'll compile and make sure all of our registrants receive. Let's see if we can get to maybe one or two more questions. How can we better advocate for better health in the DC communities? What would be the first steps? For those of you who might actually work in DC communities.
Yeah, I mean, I would first say there's a lot of the research that I helped to conduct as a part of the Early Childhood Innovation Network. A lot of our work is focused on Ward 7 and Ward 8, which is predominantly African American neighborhoods that have been divested from and divested from and historically oppressed. And I usually begin, when people ask questions such as a sort of next steps oriented question, I think it's important to take a step back and evaluate, first of all, what resources are in the community and what are the strengths and what's the resiliency that's endogenous, that's already there, in other words. And appreciating, first off, before we import our diagnoses and treatment, if you will, appreciating the lived experience and wisdom of people in the community. And that we, first and foremost, are not there to save anyone, or we're not there to implement our intervention that we've cooked up, in academia. Mm-hmm. We're there to partner, we're there to learn, and we're there to empower. So the underlying premise of that question, I would encourage that person to sort of just deconstruct and take a step back and say, who's in the community, what's there, and how can I learn from them? Mm-hmm. Rather than what can I do or what can we develop that we can implement without anyone's consent.
Absolutely. And in the interest of time, Dr. Williams made an excellent comment in our chat box here that I'd like to share with you all so we can think collectively about how we might do this, because we're not going to be able to get to all of your questions. And this is a conversation that needs to continue. So Dr. Williams suggested that, can we think about ways to keep this conversation going, maybe through social media, develop some kind of ways that we can continue to communicate with each other about these issues. So what we'll do is try to work on that and figure out some innovative way to keep this conversation going. So we'll work on that, and we'll make sure that you all get information about that when we're able to set that up. And I absolutely cannot end this panel without at least acknowledging a comment in the chat. And full disclosure, this comment is from Dorcas, who's from Accra, Ghana. So she's joining us all the way from Ghana. And as I mentioned earlier, full disclosure, she is actually my mother-in-law. So I cannot get off of this panel discussion without acknowledging my mother-in-law and her comment. That would be very inappropriate. So I'm just going to read her comment because I think it's very valuable. Thanks to all the panelists for your useful insights. In my context, stigma is the real factor that inhibits women, especially those in violent relationships, from help-seeking behaviors when they have been socialized to accept their situation as the norm. As a women's rights practitioner working with communities, I believe we should work with mental health practitioners to demystify mental health and end stigma. And I 100% agree. I think that if we are going to tackle this and overcome these obstacles, we have to partner with each other. It has to be a true partnership where we are relying on each other's expertise, talents, gifts, skills to end this. And so I think it's a very valuable comment in that it really speaks to one key role that's going to make a difference in this work that we're doing, and that's about around partnership and community and connecting and engaging. So thank you so much, all the way from Accra, Ghana, for that wonderful comment. I'm going to round us out now with our closing, and I'd like to just close with some words of encouragement. We started today's discussion with one word that described the past year, and I'd like to end the discussion by asking each of you to briefly share the following. What words of encouragement would you like to directly share with individuals who are struggling with the effects of the COVID-19 pandemic and racism and or racial injustice? Brief final words of encouragement that we can leave with our audience. Dr. Goins, will you start us off, please?
BIPOC and particularly Black women have often carried the burden of dismantling white supremacy. And I know that many of us are involved in movement work in some form. So I just want to encourage you to honor your minds and your bodies in ways that our ancestors were never given the opportunity to do so, by taking time to rest and allowing yourself to seek, find, and accept support whenever you need it.
Thank you. Dr. Walker.
That was very well said. It's hard to follow. I would just say, protect your space and preserve your energy and really keep that radical hope alive.
Thank you. Dr. Lewis?
Yeah, we've got a theme going on. What I was gonna say, as Audre Lorde's name was called earlier, and it's one of my favorite quotes of hers. So caring for myself is not self-indulgence, it is self-preservation. And that is an act of political warfare.
Thank you. And Dr. Williams?
I would say that, contrary to white supremacists, we are Americans, we are citizens, we are invested in this project for better or for worse. Our ancestors' blood has been spilled for this project. And we're going to see this project through, we're going to see it through, and just trust the spirit of the people.
Thank you. On behalf of the Georgetown Gender Justice Initiative, I'd like to thank each of you for joining us for this very important discussion. I'd like to extend a special thanks to our co-sponsors and an extra special thanks to our phenomenal panelists. I appreciate you all. I thank you. Take care of yourselves, those you care for, in both personal and professional capacities, and let's collectively commit to minding our business. Have a great day.